suicidality and basically the neurobiological underpinnings, which is something that really ties it in with the work that we're going to be doing within the P30 PET Center and other approaches. So we're very thrilled to have Dr. Oquendo with us today, even in these uncertain times. Dr. Oquendo.
Thank you very much, Anna Rose. I really appreciate it. So I'm going to try to share my screen.
Looks like you have successfully.
Can you see my slides?
Yes, we can.
Great, terrific. Well, first of all, I want to thank you for the kind invitation to come and present to you. And what I'm hoping to illustrate here is the power of PET as a tool that can be leveraged to understand relationships between neurochemistry and clinical aspects of psychiatric conditions and behavior. And obviously, I am a clinical researcher, and it's been through wonderful collaborations with radiochemists, with radiologists, and with PET imagers who are more involved in the technical aspects of data acquisition that I've been able to do this work. And back in the day when I first started doing research back in 1996, we were doing FDG PET, and when we finally started doing more targeted work with radioligands, I was one of the people who'd go down there and put in the arterial line so that we could do the sampling for metabolite analysis. So I've been involved in all of the more clinical aspects of generating this data, and really enjoy working with teams like this to try to put together, I think, novel ways of thinking about clinical aspects in psychiatry. The other thing that I would say is that it was very early on in my tenure that you all approached me to provide a pilot project for the P30, and I'm very much looking forward to, I know that it's been pushed back a little bit, but I'm very much looking forward to working with all of you to move things in some new directions, at least from my perspective.
Well, if you want to put in more art lines, there's opportunities. just in case, you missed the good old days.
Yes, well, it's interesting. Even though I'm a psychiatrist, I'm really good at procedures.
Wow.
And so in a pinch, no, just kidding.
That's dangerous information to get out.
So anyway, these are my disclosures, just so that you know. And I'm just going to start with a general overview because I know we have a very diverse audience talking about suicidal behavior. And many of you know a lot about suicidal behavior, but in general, what I want to underscore is the fact that we try to be very precise. We work to be very precise in this work because the more precise you are in defining the phenotype, the more likely it is that you're going to be able to determine what the neurobiological underpinnings are. And so I'm going to be talking mostly about suicide attempters and suicidal ideation. And when we talk about suicide attempts, what we're categorizing is behavior that where the individual has the intent to die, at least some non-zero intent. The degree of medical consequences is not considered important. And so I'll give you an example. An individual who takes a gun to shoot himself in the head, and it's usually a him, and the gun misfires, has absolutely no medical consequences from that. But that is a very dangerous behavior and a very dangerous suicide attempt. And so that's why we disassociate lethality of the behavior from categorizing it as suicide attempt or not. We purposely do not use the term suicide gesture because it gives the dangerous impression that the person isn't very serious. And we know that individuals who make suicide attempts that have low lethality, including cutting and things like that, sometimes do go on, actually often do go on to make more dangerous attempts. And so very critical to be aware that these are serious behaviors, even if it might appear to be, quote, a gesture or, quote, manipulative. The other thing that I wanted to mention is that there's often some confusion about non-suicidal self-injury. You may know that there's some individuals who, starting in adolescence, engage in superficial self-cutting or burning or other behaviors that cause damage. But in contrast to the suicide attempt, right, if you just look at the behavior, you could imagine that it's easy to confuse it for a suicide attempt. However, when you talk to the patient, they will be very clear that what they're trying to do is manage some very negative internal state. They're often trying to decrease intense anxiety. They might be trying to decrease feelings of derealization or depersonalization. And those probably have different pathophysiology than suicide attempts. And what I'm going to be talking to you about today eventually is the development of a hypothesis about the occurrence of subtypes of suicidal behavior. Again, with the idea that the better that we define the phenotype, the more likely we are to be able to find the biological underpinnings for them. So just a couple of things about the epidemiology. We know that suicidal ideation is very common. Between 5 and 15% of the adult population acknowledge having suicidal ideation. It's more common in women than men. And you should know that about 25% of adolescents acknowledge suicidal ideation. Suicide attempts are not as common in the general population, ranging anywhere from 0.4 to 1% of the population. Interestingly, also more common in women than in men, but when you look at data from adolescents, for example, the Youth Risk Behavior Survey, which is administered every other year to high school students ages 14 to 18, in that survey, reliably, 8% of males and 12% of females say that they have tried to take their life in the last year. So we don't know if it's a cohort effect or if it's just that people forget about these behaviors or embarrassed to report them later, but there's a lot of variability, evidently, in terms of what people report when they're interviewed. Suicide, of course, is a much less common behavior, but very concerning, more common in men than in women. And it varies, the rates of suicide attempt per 100,000 varies tremendously across the world. I'm going to show you a map that I just downloaded this morning from the WHO. The latest data is from 2016, but what you can see is that there's tremendous variability in terms of the rates of suicide across the country, as much as a 3 to 5-fold difference. You can see here in different areas. And as you can see, the United States has a very high suicide rate. There are about 44,000 deaths every year by suicide in the U.S. alone, and it's estimated that there are about 800,000 deaths a year worldwide. So one thing that I wanted to note is that if you look at completed suicides, about 90% of them, at least in Western countries, have an identifiable psychiatric disturbance, which makes people think that psychiatric disturbances are very critical, and they are. Interestingly, if you look at the psychiatric conditions that are most associated with suicide, the major mood disorders, only a small proportion of those individuals actually die by suicide, relatively speaking. So, for example, even for bipolar disorder, which is the psychiatric condition with the highest suicide rate, rates of suicide death in that population range somewhere between probably 12 and 15%. It's not a trivial percentage, but it's hardly the majority. So the idea is that most patients with psychiatric illnesses never attempt suicide, which leads us to this idea that psychiatric illness is not a sufficient condition for suicidal acts. Something else must be going on. And early on, the team that I worked with at Columbia, led by John Mann, took the position that there must be a diathesis or an underlying vulnerability that people have to act on suicidal ideation. And he developed the stress diathesis model, which was based on cross-sectional data and published in 1999. And what he described was this situation where you could have an individual who doesn't have any suicidal ideation, and they have a diathesis that you can detect by observing impulsivity, aggression, pessimism. And even back in 1999, we knew that the serotonin system was very important and that substance misuse was very important. And the idea is that in the context of a stressor or a trigger, which could be either a psychiatric episode or a life event, the person develops suicidal ideation and a plan and crosses over this threshold and acts on the ideation. Interestingly, the environmental risks, of course, include access to lethal means, which we can talk about more if we have time, and also lack of access to care. Also of interest is, although we're not very good at preventing life events, we're pretty good at preventing recurrence of psychiatric episodes. So we have two opportunities for intervention here: to decrease the recurrence of episodes and also to work on these other components of the diathesis to protect people. So I mentioned to you that I joined the team in 1996, and in 2004 we published a cross-sectional study in which we looked at 308 depressed patients who had extensive clinical and biological measures and had been evaluated longitudinally. And what we found is that when we followed them for 2 years, we had 4 suicides and 38 attempted suicides with a suicide attempt or a completion rate of 14%. And most of these happened in year 1, with the rate dropping dramatically after 3 to 6 months. And what we found was that the components of the diathesis that we could detect very clearly as predictive were related to aggression and impulsivity, and to a construct that we dubbed pessimism. And I'll tell you a little bit more about pessimism in the next slide. But the idea is that for individuals who had both high aggression and impulsivity and high pessimism, this is the survival curve, and you can see that these are at the greatest risk. If the individual had one or the other, either they had high aggression and impulsivity or high pessimism, they were at an intermediate risk for suicide attempt, and if they had neither of those factors, then they were relatively protected. And interestingly, the aggression impulsivity we measured using 3 different scales: the Brown-Goodwin, which measures aggression, the Barratt impulsivity scale, obvious, and the hostility scale. And interestingly, when we used a principal components analysis to generate the 2 factors I presented to you previously, but even if you looked at the scales separately, you could see again this stepwise effect where, using a median split, if you had high scores on 3 out of the all 3 of the scales, you had a much greater risk for a suicide attempt than if you had no high scores, 1 or 2. The same was true for the pessimism factor, which was from a depression scale, a hopelessness scale, suicidal ideation, and the reasons for living scale. So this very nice stepwise effect of high scores on these scales. So that was very helpful in terms of thinking about the model. So it looked like the diathesis really was panning out, that we did have this aggression, impulsivity, as well as this pessimism aspect that had some very tangible effect on the risk for suicidal behavior in the future. And what we did is that then we expanded the sample, and we were interested in, it's like, okay, so it's very important to know how to identify the diathesis, because if you're the psychiatrist in the office and the patient comes in, you want to be able to identify who's at risk for suicidal behavior. But to test the stress diathesis model, obviously we needed to see if the stressors or the precipitants that we had hypothesized, either psychiatric episodes or life events, actually had an impact on the risk for suicidal behavior in the 2 years afterwards. And here, at this point, we had over 400 patients with depression, again, followed for 2 years with naturalistic treatment. And what we did is collected data in 1 month intervals, where we determined whether the person in that month had had a depressive episode, yes, no, suicidal behavior, yes, no, and we also had their life event scores for that month. And this is just to remind me to tell you that many of these individuals, almost 60% of them reported, almost 50% of them reported childhood abuse, and more than a quarter of them had borderline personality disorder. It'll become obvious in a few minutes why I'm underscoring this issue. So when we took a look, what we found is that in the 2-year period, 33% of the participants had a major depressive episode, and 73% had reported life events. We found that the occurrence of a depressive episode, and I told you that one of the triggers that we hypothesized was a psych episode recurrence. If they had a recurrence of major depression, they were almost 5 times more likely to make a suicide attempt during the follow-up, during that month. However, when we looked at this, the effect of life events, they appear to be completely unrelated to the timing of suicidal behavior. Even during a depressive episode, there was no effect of life events, suggesting that there was no interaction between these two. And as you can imagine, we were tremendously puzzled by this because it went against everything that the clinical lore ever talked about. It certainly went against the way we think about clinically about the suicidal behavior, and also about how it's perceived by the public and the press. We're very, very worried. And one of the things, for example, one of the hypotheses that we came up with, was that perhaps what was happening had to do with cognitive dissonance, right? That if there wasn't a precipitant and the person engaged in this kind of behavior, in retrospect, they would, if you will, construe something that had occurred in the period before as a precipitant. And one of the thought experiments that I often ask people to do at this time is to think about it. I mean, to ask this today is absurd, but even during normal times, if you say, have you had anything really stressful happen to you in the last 3 months? And even during times when there's not COVID-19, most people can think of something. And so you could easily imagine a reconstruction of the events by the individual making the suicide attempt to attribute the behavior to something that had happened. So we sent in the paper to molecular psychiatry, and we often talk about the failures of peer review, but this was really a success because one of the reviewers said, you know, you have a very large proportion of patients with borderline personality disorder. Maybe you should analyze those individuals separately. And so we dutifully went back and did that, and the data was very, very interesting. So what we found is that there were very significant differences in terms of the life events that were reported by patients with borderline personality disorder versus not. So the patients who had borderline personality disorders, and for those of you who are not psychiatrists, these are patients who have very chaotic inner lives, very tumultuous lives. They're very impulsive, very aggressive, often have been abused. And they reported many more life events during the 2-year follow-up period than the patients who had depression but did not have borderline personality disorder. They also reported a lot suicidal behavior a lot more often, but the recurrence of depressive episodes was very similar in the two groups. Interestingly, if you looked at the depressed patients, and I'm just drawing your attention to the salient points here, the depressed patients who did not have borderline personality disorder, at this point, then you could see a 13-fold increase in risk when they had a depressive episode, and a pretty modest effect of life events, only 33% increment. Interestingly, in the patients with borderline personality disorder, they also had an effect of depression, but only threefold, and life events appear to be, if anything, protective. So now you can see very easily why life events were not coming out when we did the analysis with the group altogether. The other thing that was interesting is that we were looking for effects of aggression and hostility and depressive cognitions, and we really couldn't find that effect in this particular analysis. So one of the things that this led us to think about was that perhaps the relationship of life events to suicidal behavior amongst those with borderline personality disorder was more complex. Maybe we simply weren't capturing the precipitants, right? And they're very reactive and might react to things that you don't remember when you're asked to look back a month, 3 months, 6 months. But interestingly, the fact that there was not more suicidal behavior when life events occurred during a depressive episode made us think maybe there are two different independent pathways to suicidal behavior. And so we started thinking about this and trying to figure out, well, could this mean that there are two different phenotypes? And we went back to our data to try to reconstruct what this might be about. The idea that there are different phenotypes is not new. So suicidal behavior has long been known not to be homogeneous, and people have categorized it as violent versus nonviolent, as having high lethality or low lethality, being very planned versus non-planned. So this is not exactly a new idea, and even Durkheim, who wrote the first textbook on suicide in the 1800s, described different phenotypes. Subtypes. So we put together these two models, and this is not to say that these are the only two phenotypes, and if we have time I can tell you more about this, but with our data now we think that there are probably 4 phenotypes plus or minus 2. It's probably somewhere between 2 and 6, and I can tell you about that data later if we have time. But basically what we did is that we found, using our data, we found that there appear to be these two phenotypes that we could identify fairly easily. One was a phenotype that had a lot of childhood adversity, which led to reactive aggression, poor emotional cognitive control, and hypothalamic pituitary adrenal axis reactivity. In the context of a life event, these individuals develop high spikes, if you will, in suicidal ideation and make impulsive suicide attempts. In contrast, there was a different type of suicide attempter, and this is the type that the statistician would say were supernormals, because when you look at them from a neuropsychological perspective, they have fantastic cognitive control. These are very methodical, organized people. They're not at all aggressive, and they also show high serotonin 1A binding potential, both in the raphe nucleus and in terminal fields. And these individuals develop suicidal ideation in the context of a depressive episode. Their suicidal ideation is very different. It's not a rapidly moving suicidal ideation. It's rather sustained. And because of that, they make more planned and more lethal suicide attempts. So we wrote a grant to try to explore these two models. And I'm going to show you some of the data that we used to build that argument, and then I'll also show you some of the more recent data that we have. So one of the things that we found, for example, is that whether you looked at patients with mood disorder or patients with personality disorder and mood disorder, we found that people who had childhood trauma tended to be more aggressive. So here you could see statistically significant differences in the mood disorder individuals as well as in the borderline plus mood disorder individuals, where those with childhood trauma had higher aggression scores than those without. Interestingly, in the latter sample, those with childhood trauma also had a lot more variability in their suicidal ideation. And they tended to react to events such as disagreements or rejection by others. These are fairly minor things with higher increases in suicidal ideation. And here are some samples from individual patients where you can see what the suicidal ideation looks like. This is collected using something called ecological momentary assessment, where we give patients, using their own smartphone, we ask them to provide data 6 times a day for a week and ask them about suicidal ideation. We ask them about mood. We ask them about anxiety. We ask them about life events. Fairly modest life events. These are like more like everyday hassles or upsets rather than anything major. And what you can see here is that the high aggressive impulsive individuals had this very pronounced variability in their suicidal ideation over the course of a week. Here's another example of a high aggression and impulsive individual, again showing this very, what we call spiky suicidal ideation. In contrast, the low aggression impulsivity individuals had much less variable suicidal ideation, and sometimes it was elevated, but whether it was elevated or not, it tended to be much more steady. And interestingly, what we found is that these were significant differences when we looked at people who had high scores on aggression and impulsivity, and we also found that the 9 life events that I mentioned to you, for example, had a disappointment, had a fight with someone, felt rejected, had a very important impact on increasing suicidal ideation for the highly aggressive and impulsive individuals. Interestingly, these high impulsive and aggressive individuals also had a very hard time harnessing different brain regions when trying to regulate emotion. So this is an analysis of 46 suicide attempters compared to 14 non-attempters who had recalled aversive personal memories and were then instructed to either immerse themselves in the memory or distance themselves in the memory. So what that requires is for the individual to regulate their emotions, to be able to distance themselves from the emotional impact of the aversive personal memory. And what we found is that the non-attempters were much better able to recruit precuneus and orbital prefrontal cortex when distancing. And the precuneus is an area of the brain that is important in self-awareness and perspective taking, which obviously would be important for emotional regulation. And the orbital frontal cortex is extremely important in integrating information about rewards and punishments so that you select the appropriate response and inhibit inappropriate affective responses. So it makes sense that these regions would be less active in individuals who actually were attempters. We also did some laboratory experiments where we exposed people to stressful situations. This is the data from the Trier social stress test. In this test, you have 3 very stern-looking examiners in white coats with the subject. The subject provides salivary cortisol during the procedure. And during the procedure, the person is asked to do arithmetic calculations at ever-increasing speed, and also to do an autobiographical description as if they were at a job interview. And here again, what we found is that the people who had the high aggressive and impulsive scores mounted a much more robust cortisol response during this laboratory test of stress compared to the ones with either high aggression or high impulsivity, or those with both low aggression and impulsivity. And interestingly, this greater cortisol response predicted an increase of 5 points in suicidal ideation during the follow-up. Again, putting together this idea that there's this constellation of characteristics that these highly impulsive and aggressive suicidal individuals exhibit. And here's a different analysis looking at the same test in a different sample, the Trier social stress test. And here again, you can see that individuals who reported having only brief periods of ideation, as opposed to more continuous ideators, had a more pronounced salivary cortisol response, whereas the people with longer continuous ideation were more like the healthy volunteers. So I just summarized for you this idea that childhood adversity leads to poor emotional cognitive control, perhaps, and this reactive aggression, as well as HPA reactivity, and that this constellation predisposes individuals who, in the context of a life event, express this high increase in suicidal ideation, leading to more impulsive suicide attempts. So now I'm going to shift to talking about the other phenotype, which is where the PET imaging comes in. And just to refresh your memory, we were talking about these people with incredibly good cognitive control, people who are not at all aggressive, and with this high 5-HT1A binding potential that develop sustained suicidal ideation, but in the context of a depressive episode. It's not about a stressor, and make more planned, more lethal suicide attempts. And what I'm showing you here is that if you look at attempters compared to non-attempters, you can see very clearly that the attempters tend to have higher scores of aggression, and this is very highly significant. And interestingly, the low aggression attempters, if you look at just these attempters over in this area of the curve, of the distribution rather, of the histogram, these low aggression attempters had fewer past attempts and were less impulsive and less hostile. They also were less likely to have childhood trauma. And although they made as many attempts as the more aggressive attempters, their attempts were of higher lethality. The mean lethality was 6. A lethality of 6 means that the suicide attempt was severe enough that they had to be in an intensive care unit. Also, their 3-month depression scores were higher, and they reported fewer life events during the follow-up. So we had been using during this time whey, which the whey compound whey is a antagonist. Whey 100-635 is an antagonist at the 5-HT1A receptor. And we collected this data with arterial input functions. We measured radioligand metabolites for the first 60 minutes, and we also had measures of plasma free fraction. The regions of interest that we looked at were the raphe nuclei, amygdala, hippocampus, parahippocampal gyrus, and then an anterior cingulate, medial and dorsolateral prefrontal cortex, as well as insular parietal, temporal, orbital, and occipital cortices. And these are standard regions that we use in our analyses. And the regions of interest were hand-drawn by highly trained, experienced techs and they were based on brain atlases and published report. For the raphe nucleus, because you can't really reliably identify it, we used an elliptical fixed volume region of interest in the dorsal midbrain on a mean PET image from each of the individuals. And the white matter reference region was defined using a cylindrical region of interest in cerebellar white matter. This is just some of the information about the collection of the data. These are long scans. This individual has to be in the scanner for 110 minutes for collection of 20 successive frames of increasing duration. Because they're in for such a long time, as you can imagine, there's a tendency for some motion, so we need to do motion correction. And you can see in this slide that there's a tremendous amount of processing of the data that happens before we can actually convert it into the types of data that can then be used to conduct tests of their association with clinical parameters. And here is one of the things that we found really to be very interesting. So this, on the x-axis, we have the duration of ideation. -1 means that the person didn't have any ideation. 0 meant that they had very brief or fleeting ideation, and 2 meant that they had very consistent ideation. And this is the binding potential, BPF, for the 5-HT1A receptor. And these are the different regions: raphe, amygdala, hippocampus, hippocampal gyrus, temporal, anterior cingulate, etc. And what you can see here is that for all of the regions, and the amygdala was only at the trend level, but for all of the regions, you could see that there was a greater binding of 5-HT1A across both terminal fields and also at the raphe nucleus, suggesting that this greater binding potential was associated with the more persistent suicidal ideation in these more, shall we say, controlled suicide attempters. Interestingly, we also looked at neuropsychological tests. We looked at the Stroop interference. The Stroop test is a very interesting test in which you ask individuals to determine the color of the font that a letter is, that a word is written in. And on some of the trials, the font is the same color as the word, so it might be the word blue in blue font. But in some trials, the font is a different color, so it might be the word blue in red font. The interference effect is the delay that's recorded when the individual is looking at a discordant word. So when they look at the word blue in red font, they're going to be slower for the most part than if it's blue in blue font. And that interference score is something that we have found to be decreased in individuals with high lethality suicide attempters. We've reported that in the literature before. And here what I'm showing you is that, again, across all of the regions of interest, you see a modest but statistically significant association where the lower the interference, meaning the better cognitive control, right? So if you're really good at being razor focused on the task at hand and you're not distracted by the color of the by the word to determine what the color of the font is, that means that you really have low interference scores and you really are very well able to ignore extraneous distracting information. And here you can see across all of the different, all 12 regions, that individuals with lower interference scores, these are Z-scores, by the way, for the Stroop interference, the lower the interference scores, the higher the 5-HT1A binding. Again, going along with this idea that people with higher binding have much better cognitive control. And this was also true in terms of there's another task that we do called the continuous performance task, which is also an attentional one, and people who had higher 5-HT1A binding also were very conservative in their response bias on this test, again suggesting that these are people with excellent cognitive control. One thing that people often ask is, what does it mean that you would think that there would be a discrepancy between the raphe nucleus, which I like to think of as the knob on the radio that turns on the volume for the serotonin. I know that's a very sort of blunt description, but what we think is that people who have, as you know, at the raphe nucleus, the 5-HT1A receptor is an autoreceptor. So if you have higher binding potential in the raphe nucleus, that means that the autoreceptor is actually turning down the volume, if you will, of serotonin. So it's decreasing the serotonin neurotransmitter. All the cell bodies are in the raphe nucleus. And we think that the terminal fields are responding by upregulating postsynaptic 5-HT1A receptors. And interestingly, what we found is that not only were the people with the higher 5-HT1A binding more likely to have higher intent, but they also had higher lethality and higher planning scores. So this again goes along with this idea. These are not people who do things impulsively. These are very methodical, planful individuals who think very carefully about what they're doing, even though to us it might seem like a very irrational behavior. And so again, just to recap, what I've shown you is that these are individuals they have 5 very high binding potential, excellent cognitive control, they're not aggressive or impulsive, and in the context of their depressive episode, they develop the suicidal ideation. I didn't show you any evidence for this, I apologize, but I do think that you can see that this seems to be very closely linked, and at least there seems to be some good reason to believe that the sustained suicidal ideation, which would give people more time to plan their suicide attempts, would lead to more lethal suicide attempts. So I'll take questions in a minute, but I just wanted to, Anna Rose, this is for you. This is the nod to the P30 pilot project. As you know, I worked with Marty, Kyle, and our wonderful T32, Dr. Regier, to put together this Kappa Opioid project, looking at a population with comorbid pain and opioid use disorder. As you know, both of these conditions separately are increased risk for suicide, and together even more so. And what we hypothesize, as I've just mentioned to you, so the subgroup with variable suicidal ideation, they react to environmental stressors, but we know that their HPA axis is likely to be dysregulated, but we don't really know what other brain substrates are involved. The Kappa receptor, which is downregulated in people who report childhood abuse and who have been traumatized, is a very good candidate for this. And interestingly, the effects appear to be mediated by cortisol, which goes together very nicely with the data I just showed you. And so the question is the dynorphin Kappa opioid receptor system relevant to variable suicidal ideation? And you know, there are a couple of radioligands, and I think that by the time we get to do this study, hopefully we'll have really good data about the best radioligand to select. But we know from preclinical research that there is dysfunction in the dynorphin Kappa opioid receptor system in addiction and in pain, and that their prolonged signaling can lead to persistent behaviors characteristic of depression in human studies as well. And so these are the aims, so to characterize the baseline Kappa opioid receptor availability in those with comorbid pain and OUD. And then we'll also assess suicidal ideation using this ecological momentary assessment and look at the relationship between Kappa opioid receptor availability in amygdala and other limbic regions to see if they're relevant for the variable suicidal ideation. And hopefully, if we find this to be true, this would be interesting because medications such as buprenorphine, which has an antagonist effect at the Kappa opioid receptor, has been shown to reduce suicidal ideation, so it might, in patients with OUD and pain, so it might be an explanation, if you will, for that finding. So I'm going to stop now and thank my collaborators. Of course, this is the work of lots of people, as I already told you, and with that, I will be happy to take any questions.
Maria, a very impressive publication, but I have to say What I'm most impressed about is you did 134 subjects with a 110-minute protocol with A lines and metabolites. How long did it take you to do that, and how did you manage to get that many subjects to undergo that procedure?
So that's a really good question. It is not easy to get psychiatric patients to sit in a scanner. And by the way, we were also doing DASB at the same time. So they were doing 2 sessions in one day after being washed out of their medication. I didn't even mention that. We do wash out all of the patients from their medication as well. And it really is critical to have very trained, highly trained techs that are very empathic and really literally sit with the subjects and spend a lot of time with them. There's a lot of hand-holding that goes on. We try to minimize taking people out of the scanner and putting them back in, but of course we have a head holder that was molded to the individual's shape of the head to try to make sure we could reposition people. That only happened a couple of times. Now, we collected this data over a period of about 8 years across 2 different Conti centers. So this was, really a very long, protracted study.
Yeah, no, we were very proud of ourselves for acquiring a fewer number of breast cancer patients who did not have to go A-lines and had a shorter dynamic study. But that took, probably 6-7 years, and probably cancer patients are a little bit more willing subject than suicide patients. That's impressive. Thank you.
Thank you.
Maria, this is just a question from naivete, not from knowledge. I know that you're mentioning from the 5-HT1A imaging that you were looking in terms of autoreceptor hypotheses. Where are the 5-HT1A postsynaptic receptors? Just curious about that and how one would go about parsing it. I know that we had what we thought was some 5-HT1A binding with a tracer that was studied earlier, and I just wondered, thoughts about that?
Yeah, so the postsynaptic 5-HT1A receptors are all in the terminal fields, meaning cortex, amygdala. So all of the serotonergic cell bodies are in the raphe nucleus.
Right. Yeah.
The autoreceptors are on the raphe nucleus, and the postsynaptic receptors are in.
In the many places that those projections go to, I guess would be.
So they project all over the brain, including to cerebellum, and in their postsynaptic 5-HT1A receptors are very widespread.
Mm-hmm. So when you do the imaging, and this is again out of naivete, do you just essentially you're doing your region of interest, and that gets rid of all the other places that you would have hotspots from the postsynaptic binding?
Right. Well, there are areas that have higher density of 5-HT1A binding than others. And if you look at the images, you can see that very clearly. But they are fairly widely distributed, even if at different densities.
Yeah, but fortunately you can go for the raphe, and that helps, obviously, that constrains it, so that's really helpful.
Yeah.
Thank
you.
But and I'm also really interested in the phenotypes. Obviously, when we read through your work and we're thinking of points of intersection between that and the substance disorder patients, it did seem like there was a good matchup between the variable subtype and what we see in many of our patients. Most of them have a lot of sort of impulsive features, and even there's been brain studies characterizing the fact that they have reduced sometimes top-down modulation. For again, my knowledge, I know we have a proportion of them that are also borderline personality disorder.
Yeah.
But maybe not the percentage that you might expect. In other words, we have people who are on a continuum, but a full-out, flat-out borderline is a memorable experience, and it's not something that we see every day, right? Or we would be we would be running to CVS. We'd be running to CVS for hair color even sooner than we do. So I just wonder in terms of the continuum here. I'm thinking about it. that even without borderline, we're going to be able to have something that we think will be a detectable subgroup.
That's a really great point, Anna Rose, and you reminded me that I didn't make it clear that one question that the reviewers asked in that paper that was saved by the reviewers was whether all of the people with suicide attempts that were precipitated by life events had borderline personality disorder, and the answer is no. And in fact, the other thing that we just recently, I just submitted the second round of revisions for a paper looking to see if these phenotypes run true, at least over a 2-year period, and it does look like they do. So one question that we had was, well, are these characteristic of the person, this type of suicidal ideation, or can people go back and forth between variable suicidal ideation and persistent suicidal ideation? Mm-hmm. What we found is that at least over a 2-year period, they do seem to be quite consistent. And we did find the effects of childhood abuse in terms of being associated or predicting statistically the occurrence of more variable suicidal ideation. So I'm hoping that paper will be accepted shortly. Wish me luck.
We'll look forward to it. And the childhood history of abuse, I think Paul Reguer is on the call, is actually interesting in terms of basically these things traveling together. You know, right. the type of suicidality and the early adversity, which can then manifest in everything along the continuum up to and including borderline, but even short of it.
Right.
So that's so intriguing for us. We really look forward to getting to the next stage. I'll shut up and let somebody else ask.
Maria, thanks so much for such a beautiful description of the suicidality phenotype. And I know that when we first started working on DSM-5, there was a lot of discussion of a potential suicidality genotype that was independent of psychiatric diagnosis. And I just wonder whether those efforts have led to any more light on this, because one of the interesting things about starting a psychiatric practice in the city where you trained is that all the patients are referred to a young psychiatrist by other psychiatrists who skim off the, quote, good patients and give all the borderlines to the new person because they are so difficult.
Yes.
But and I always wondered how this genetic work was coming along.
Yes. Well, thank you for raising that. Actually, you may or may not know that I was the person who proposed that. And I am extremely stubborn, so I'm still working on it. Just recently, the American Psychiatric Association went through a process where they did not agree to add it as a separate diagnosis in the body of the DSM, but they did agree to add both suicide attempt and non-suicidal self-injury as items to be coded in the diagnosis. The idea is that the best conserved data in a medical record tends to be the diagnosis, and that if you're going to keep your eye on people who are at high risk, namely past suicide attempters, it's got to be somewhere in the diagnosis. So I'm still working on it, and the idea that we have is that if this gets approved by the APA, and it should be, hopefully it's coming before the board in July, and if it is, then what we'll do is work with the Joint Commission to get them to insist that these codes must be used as a matter of course for patients who are suicidal. So we'll get it done by hook or by crook.
Thank you.
Other questions? What about flat out genetics, regular genetics in terms of basically favorite SNPs or something broader, your favorite GWAS? How does that intersect with the field of suicidality at this point?
Well, interestingly, they're very, we actually published a GWAS, but it only had 8,000 patients. I think that's one of the challenges, right? Is that really to be able to find these associations, you really need six figures in terms of your patient population, and that's really challenging because not too many people study suicide.
Right.
For the same reason that Chuck was saying, people are afraid to be involved with these populations. They're very difficult to manage.
Right.
What are your thoughts about cross-cultural applications, like your ritual suicide?
Well, that's a really interesting question, because even in countries where ritual suicide, quote unquote, are considered acceptable culturally, or had been, those governments, like the government in India and in Japan, have very robust suicide prevention efforts. And the governments there are very consistent about not viewing this as an acceptable outcome and something that is to be prevented. So it's sort of an interesting thing. Good question.
I think we have one more minute if anybody has a final question.
Great talk, thanks. I was just wondering if you could say more about, you said you thought that there's more than 2 subtypes.
Oh, yes.
Say more about.
So in using different data sets, we did another analysis where we used data from college students and graduate students, about 6,000 patients, and we did a data-driven method to try to determine how many different groups there were, and we found 6. There's a group at Harvard that also uses ecological momentary assessment, and they have reported, I think they reported 5. So that's why I always say it's probably 4 plus or minus 2. It's probably not more than 6, and it's probably not less than 2. But if I were a betting woman, I'd bet on 4.
We'll keep that in mind. That's great. And when your paper does come out, be sure to give us a heads up so we can look forward to reading through it.
Thank you very much. I appreciate that.
And as things move forward and as research eventually returns to campus, we'll look forward to seeing the pilot study take legs.
That would be great.
Thank you so very much.
We'll start back towards the 100 PET scans.
The N is much more modest on this one.
Oh my goodness.
We're up to the jump.
Thank you very much. Really appreciate it.
Thanks very, very much.